Welcome to our Grand Rounds series. Our Greenberg bladder cancer team is grateful you're here. Of course, seeing you in person would be preferable, but these virtual platforms have proven to be very efficient for sharing information, for education, and most importantly, for discussion. First, a couple of updates. We've updated our calendars and are proud to bring you an incredible portfolio of courses over the next couple of months. If you are new, please find our archive program of sessions from over the last several years. Over 20 sessions are available to view. Our next virtual Grand Rounds will be held on March 28th, when we will have a presentation on chemobrain. For updated information about the Institute, be sure to simply Google Greenberg Bladder Cancer Institute. Furthermore, I wanted to once again draw your attention to our evolving group of programs, specifically tailored around the experiences of women with bladder cancer, developed and led by Drs. Armin Smith and Jeannie Hoffman-Censits, and the program team of Pamela Getz, Samantha Rockler, and Stephanie Cooper Greenberg. Our next women's group session will be held on May 22nd, when the group will be discussing stress, depression, and cancer, a topic I'm sure you'll all be interested in hearing about. Their programming details are available on our website, and of course, please never hesitate to reach out, and we will send you the details directly. Again, all of this information and more is up on our website, and if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. I'm incredibly grateful to all of you for joining us today for our session, New Tools in the Toolbox Explained, a conversation about new drugs and therapies. I'm grateful to Stephanie Cooper Greenberg and Dr. Jeannie Hoffman-Censits for joining me in our conversation today. Dr. Hoffman-Censits is an associate professor of oncology, and as most of you know, she's a medical oncologist who co-leads our GBCI program in upper tract urothelial cancer with urologist Nervous Singla, and also the women's bladder cancer program with urologist Armin Smith. In addition to taking care of patients, she manages an innovative portfolio of clinical trials in bladder cancer. In particular, she has a national leadership role in clinical trials in upper tract urothelial cancer. Dr. Hoffman-Censits received her undergraduate degree in neuroscience from Trinity College. She earned her MD and did her residency at Thomas Jefferson University before performing a fellowship in hematology and oncology at Fox Chase and Temple University Medical Center. She joined our faculty in 2018. We are also exceptionally grateful to Stephanie Cooper Greenberg for joining us today to moderate our important conversation. As co-founder of our institute with her husband, Erwin, Stephanie is a tireless advocate for bladder cancer patients and their families. Aside from all of the heavy lifting she does for us here at GBCI, she also serves as a patient advocate on the National Cancer Institute's Bladder Cancer Task Force, which, as many of you know, plays a leadership role in designing the National Clinical Trials Network's cooperative group clinical trials. In addition to her important work in bladder cancer, Stephanie serves as Johns Hopkins on several boards, from the Children's Center to the Center for Innovative Medicine to the Brady Urological Institute. She also serves on the Maryland State Council on Cancer Control. Before the pandemic, it is entirely likely you may have bumped into Stephanie many days during the week with her therapy dogs, making the rounds across Hopkins. A warm welcome to you both, and thank you for joining us today. I would ask for folks to please submit questions via the chat feature, and after conversation, we'll have ample time for group discussion.
Great. Thank you, David. I get to turn the tables and ask the questions, a lot of them today, and I'm really thrilled. It's a humbling moment for the Bladder Cancer Institute, which is actually started around 2014. And when Jeannie was so kind, she's going to have fantastic slides, by the way, which we will post on our website so you can have. There's a lot of material today, so take notes, and especially if you have questions, type them in the chat and we'll ask them in real time, because this is real science, real details, things that are really important to know about, and new tools in the toolbox that are in real time. But I'll say this, in 2014, there were very few clinical trials. There was no immunotherapy, didn't exist yet, which is kind of hard to absolutely wrap your head around. And the only thing really available was BCG and the standards of care, which continue today. But there's a whole lot of new things for patients that is extremely beneficial, and it's become sort of a golden age for bladder cancer. I sit humbled with to ask David McConkey questions. He's hard at work, not only as director of our institute, but also as a leader in research. The research portfolios worldwide in bladder cancer have blossomed, I mean, exploded in the past almost 10 years. And Dr. Hoffman-Censits is, goes without saying how fabulous she is. Also, I might add that we're having a special session toward the end unique to upper tract urothelial cancer, which is kind of a bladder cancer, but it's kind of its own. And Jeannie has become a world expert, and Hopkins has become a place where people really come and seek out care. So more on that later. So grab your pencils, please ask your questions. No question is no question is a dumb question. I'm going to be the one to say, wait, what does that mean? Can you slow down? What's the science? Our Dr. McConkey is our mad scientist. We love him. And Jeannie also speaks English. So let's try and keep it in English so it's helpful to you. And for those of you who are being treated for bladder cancer or are curious or are a caregiver, thank you, caregivers out there. This is also an important little conversation to know what to ask for. That's really important so that you know and are well informed. And again, we have the backup materials on our website. This will be recorded and reposted to know what to ask for if you are not treated at an academic medical center, because the field has totally exploded. So first things first, I'm going to ask Dr. McConkey to give us an update on BCG, which we all know has been a standard of care for bladder cancer for many, many years. First of all, the origins of BCG, if you didn't know, are really kind of fascinating. It's kind of the original immunotherapy drug. It was developed in 1921 by French scientists, and it was used to protect the lungs of those with tuberculosis, and is still used today. In 1976, through wonderful discoveries or happenstance, it was discovered that BCG used in bladder cancer was a very effective therapy when instilled in the bladder for bladder cancer. And so BCG has been a standard of care since 1976. It's taken till about 2015 for new stuff to come along. BCG, however, is still the gold standard for non-muscle invasive early disease. There's been some problems, however, with BCG. There's been immense shortages that you've heard about, and I hope not too many of you have experienced those shortages. There's one manufacturer, Merck, who makes it, only one in the world. And there's been supply issues with contamination and so forth. It's a live bacterium. It's complicated to make. Not many other drug companies clearly are, in the business. So there've been shortages that have been plaguing the bladder cancer community for far too long. So I'm going to ask David to give us an update on where we are with BCG. Are there still shortages? And most importantly, are there new alternatives coming along for BCG?
Thanks for that question. So just to be completely up to date for our conversation today, I reached out to Dr. BCG, my colleague Ashish Kamat, and he has confirmed that we're still having challenges. Things have not gotten that much better. So that's kind of the bad news. The good news is that we completed, as many of you know, a phase 3 clinical trial comparing the Merck strain of BCG, which Stephanie just described to you, to one that's been developed in Tokyo. And as soon as the FDA decides that they're equivalent, we will have a second source of BCG. That's still the data are still being reviewed by the FDA. But in addition to that, there are a lot of other things that are happening in this space. So as hopefully all of you know, Max Cates here at Hopkins is playing a leadership role in developing gemcitabine blastositaxel chemotherapy delivered into the bladder as an alternative to BCG for the same group of high-risk non-muscle invasive bladder cancer patients. He's got a phase 2 clinical trial that he's leading here, and he's also leading a phase 3 trial called the Bridge trial that will be performed in the cooperative groups to compare gemdosi directly with BCG in a head-to-head manner. In addition to that, we've had some approvals. So Adstiladrin, which is an intravesical and in the bladder immunotherapy, was just approved for BCG unresponsive disease, and the company plans to move it forward into intermediate risk. And we've also seen other drugs that have been developed that stimulate the immune system in the bladder that are also moving forward. All of that's great news. But then again, there's also the issue of other work that's showing us that BCG combined with immunotherapy like checkpoint inhibitors and other drugs can actually work in patients who have BCG unresponsive disease when it's combined this way. So I think there's a lot of excitement for our patients, but there's also going to be continued, maybe even increased pressure on BCG supply as these combination therapies with BCG get developed. So
I have a question. A lot of people,
Yeah.
BCG is tough for some people and they can't tolerate it, or it doesn't even work. With these new drugs, or they're not actually new drugs, they're plentiful in supply. They're old chemotherapy drugs, Gemdosi, for example, which is what it's called. Is that an alternative to BCG for people who can't tolerate BCG? Is that
yes,
how it works?
right, it is. And also, when BCG is in short supply, the choice is either to cut down the dose, which we're not sure is a good idea, or go to an alternative. And again, the data are still being developed with Gemdosi, but urologists have been using it for quite a while. Mike O'Donnell at the University of Iowa has been also using it for quite a while. And even though their experience isn't documented within the context of a clinical trial, randomized clinical trial, it seems by all accounts to be very active in patients with this high-risk disease.
Terrific. Now back to the Bridge trial, which is Max's phase 3 trial, and the results were pretty stunning. That it was fairly effective with like a 70% response rate. Is that correct in the phase 2 trial?
Right.
People enroll in the trial. Is it across, at many institutions? How do they learn about the Bridge trial other than calling, emailing us? We'll send you information because we are the host for it, but it's also at many other institutions in the country. Is that right?
I'm not sure that it's open yet, Stephanie, but as soon
it is open. Yes,
Yeah?
it is.
Okay, so then the best way to do it, I think, is for them to reach out to us. But the second best route would be through the clinicaltrials.gov website or any other academic provider at an academic center. Everybody knows about this trial, and it's being opened across the cooperative groups. So I think any of those approaches works, but for those on the call, the simplest would be just to reach out to us.
Fantastic. Great. And so good alternative, maybe Gemdosi, Bridge trial, reach out to us or just look it up. I mean, it's an open trial and
Right.
it's been a couple of months ago. And the early preliminary data, which Max, Google him, had already published was super promising. So that's a nice alternative and it's in plentiful supply.
Right.
Talking about these combinations, I think this whole talk is really about all these fantastic new drugs and how you're making cocktails of drugs all the time, these immunotherapy drugs. It's all these weird names. By the way, I want to ask a definitive answer. I have noticed immunotherapy drugs end in IB, like Nivolumab, or the end letters of a drug indicate what kind of drug it is. Can you help us with that?
Yeah, sure.
Curious
So
about crazy name.
Yeah, the official names for drugs that are antibodies, like Nivolumab or Pembrolizumab, end in MAB because that stands for monoclonal antibody. And I think Jeannie's going to introduce us to a picture of what a monoclonal antibody looks like later. IB, MIB, usually refers to something that is a chemical. So erdafitinib, which is a drug that many people are familiar with because it's being used to treat patients with activating FGF receptor 3 mutations and fusions, is a chemical. So it's a synthetic compound. So
GF, we're going to explore that.
Yeah.
Other question, with all these cocktails, Noah, our own Noah Hahn, has his ADAPT trial, which incorporates BCG and immunotherapy. Can you comment on how that trial is going and what it is?
Beautiful. Yeah. So he's got a paper in press at European Urology that describes the results you're referring to. But the complete response rate with a combination of BCG plus the checkpoint inhibitor durvalumab are extremely impressive in patients who've already been treated with BCG and developed BCG unresponsive disease. So this is kind of what I was referring to earlier. The fact that we can retreat patients with BCG and see this tremendous benefit when it's combined with immune checkpoint inhibitors means that it's going to open the floodgates for demand for BCG within this context. But that's good news for our patients.
In the context of the ADAPT trial and the BRIDGE trial and BCG combos, we're talking about non-muscle invasive disease. Correct?
High-risk non-muscle invasive. Yeah, so NOAA's also investigating the combination of gemcitabine docetaxel plus durvalumab. Now, the results there are still not yet mature enough for us to say much about it. But suffice it to say, we'll know if this gem-doce combination works as well as BCG does when it's combined with an immune checkpoint inhibitor in this disease state.
It's maddening out there. It's sort of like, belly up to the bar and ask for like a vodka gimlet, a gin and tonic. It's all these different mixtures and combos. And what's so fascinating, in 10 years, there was no combo to mix 10 years ago. So the science is moving fast and there's a lot of creative minds. I say this because of the Bladder Cancer Task Force. Incredible ideas keep floating around. They're fascinating when I understand them. But there's a lot of good, robust things going on. Now we're going to switch to our beloved Jeannie, our oncologist, to give us an idea of how these at least 10 FDA-approved drugs have come on the market, what they are, how they work, and how they're used, and how Jeannie, in her practice with her patients, whether bladder cancer or upper tract, deploys these drugs in patients and for who. But let's start with Jeannie and her slides. We're going to talk about a couple of things you've heard about, folks out there, which you don't know what they are. At least I didn't. Monoclonal antibody. What is that? What is actually immunotherapy and how does it work? What is an FR receptor? We are watching the news at night and then there's these ads come on and we have no idea what they're talking about. Like, what is that? And I think, sorry to be so simple-minded here, but I think our patients need to know how this all works. This is all fascinating chemistry. So thank you, Jeannie, for making it simple for us. And here you go. And
Thank you.
The questions, let's see. David, we're not done with you yet. Is there anything patients can do to apply pressure on the FDA to complete the BCG Tokyo approval?
No, I think pressuring the FDA never works. No, I think it's just going to take a little more time, but I think we're going to hear an answer pretty soon. The package has been submitted for a while now, and I anticipate we might be hearing something soon.
Great. On that note, not to let you go yet, David McConkey, the Tokyo strain, the question is, does the Tokyo strain, a BCG, versus the Merck strain have similar side effects as the Tice strain? The Tice is the Merck strain. Tice and Merck versus Tokyo, do they have the same effects, side effects?
So again, the details of that are being reviewed by the FDA, but having been witness to the trial, I can tell you that there was nothing unusual about the Tokyo strain with respect to the Tice strain. And we didn't really expect that because other strains have been used across the world previously. So.
And then, Margaret, thank you for your question. I think you're going to start to hear the names of specific drugs that David mentioned, durvalumab, I can't even pronounce these things, in the next section. So if you have questions, we will absolutely stop and say, what drug were you talking about? But there are different kinds of drugs and they're all in these classes. Jeannie's going to go through that right now. Again, with these cocktails. And then Susan just wrote in, how long can you stay on gem-doce? That's a Jeannie question. And Jeannie, I'm going to let you answer that one.
That's a good question, but I don't have the answer to that. That's more of a Max Keith question.
Yeah,
I think that we're still gaining experience with this combination. So I think it's going to take a while before we know some of the details like that.
Right.
So
Okay.
with regard to the other drug, Margaret, it's called Adstiladrin now. It used to be called something called nadofaragine, but it's been switched now to Adstiladrin. That's its new name. So.
Okay. Jeannie, it's all yours. And Margaret, if you have any questions, let us know. And you can also reach out to us. These slides will become available and all the names of the drugs are on the slides.
Okay. So is Wasim gonna put the slides up, Stephanie?
I think he said you were going to share your screen.
Did I say that?
No, I think he said that to us, but.
Sorry about that.
Okay, that might take a moment or two. I wound up coming home, so I am not.
I can share the screen.
Yeah,
Oh,
go ahead, Wasim.
You're the best. Thank you. Sorry about that. I love how we're all so much more facile on sharing screens and switching things around nowadays.
Well, Wasim's the king. He was the first one I ever saw host a Zoom meeting in March 2020. So
That's awesome.
he's the king of Zoom.
And Wasim, are you going to advance the slides?
Yes.
Okay, awesome. So, thank you so much. This is such a great intro to talk about the intravesical therapy and treatment within the bladder. So kind of to be clear, and the lines get a little bit blurred here at Hopkins, but for the most part, I think here at Hopkins and as well as other academic centers across the country and community cancer centers, anything that goes inside the bladder, almost like topical therapy, like you would use on your skin, same idea, kind of treatment on the inside of the bladder. 99% of the time that is done by urologists like Dr. Cates and Dr. Singla and Dr. Armin Smith. Here at Hopkins, we have a medical oncologist that gives systemic therapy like chemotherapy, named Dr. Hahn that Dr. McConkey brought up, that he has an interest kind of living in both worlds, giving advanced cancer treatments for localized bladder cancer. So that's part of his research program. So some of the questions that I couldn't answer is just because I don't give the medicines in that space, in that setting. But I think a great segue into a future slide deck dedicated to intravesical therapy or PASS, which I'm sure you have. So one of the things to think about is, the difference between low-grade cancers and high-grade cancers. And this is important. This is what kind of comes out in the pathology reports. When a TURBT biopsy is done, that transurethral bladder tumor resection, or when someone has a resection or a piece of tissue that comes out of the upper tract, your urologist is getting this information, and then the pathologist looks at it under the microscope and renders a diagnosis. And one of the things that we're looking at is understanding, is the tumor high grade or low grade. In general, the medicines that we give as medical oncologists through the vein, oral, those systemic therapies, we're treating high-grade disease. So high-grade bladder cancer, as well as high-grade upper tract disease. So very rarely are any of our medications really used for low-grade disease. There is the one FDA-approved drug called Mitogel. It's a topical therapy for upper tract disease, and some of the intravesical therapies. But for the most part, we're going to be talking about high-grade disease for these newer drugs. Next slide. So this is just an overview of, that explosion of drugs that have been approved, since really the 70s. So Stephanie, you said it best, really, things have changed dramatically. And I recall when I was making a decision about a career path, there's so many things about urothelial cancer that were interesting to me, as a trainee and as a fellow when I was very early on in my career. But one of the things that was very interesting was just this empty landscape, that really nothing had been approved in so long. And I thought to myself, could probably help with that. That was a challenge. And of course, all the interactions that we have with urology and some of the very special considerations that we have to think about for our patient population were very attractive. But as you can see, you talked about BCG being FDA approved in the 70s. And the same was true with cisplatin, and then just nothing for such a long period of time. So, in the past decade, we've really seen this acceleration, as you mentioned, which is super exciting. So this is a busy slide, and that I'm going to do my best to try and break down all these different drugs in terms of what they are and kind of how they're given. Next slide. So again, when I kind of first walked into this field, up until the spring of 2016, when we thought about treating patients with either metastatic bladder cancer or in the what we call the perioperative setting, either before a cystectomy or nephroureterectomy or afterwards, it was really kind of one decision tree. Are they a candidate for cisplatin-based chemotherapy through the IV or not? And if not, is there an indication for chemotherapy? And if there is, then they would get carboplatin-based chemotherapy. And if someone wasn't well enough for that, either they were too frail, or their kidney function wasn't good enough, or they had bad peripheral neuropathy, we were worried about making that worse and causing falls, then we just did what's called best supportive care, just kind of watching them, pain medications, things like that. So this was the landscape that existed for so long. It really was, not serving our patients very well. And this is the current landscape on the next slide. Pretty complicated, but also like pretty exciting, because this is all the things that have changed since the first FDA approval of the checkpoint inhibitor immunotherapy that happened in 2016. So there's been this huge acceleration. And so this is the map that we're going to have in our head when we meet new patients with advanced urothelial cancer in the clinic, the different disease states that we treat and the different drugs and the way in which they're given. I think one of the challenges that we have now, I say this is kind of like a yard sale slide. If you ever walk up to a yard sale and you're trying to figure out, where to look, you don't even know where to look because everything's kind of strewn everywhere. That's a bit like we are now, in bladder cancer. We have all these different options, and some sense in terms of the dogmatic approach to using them in the order in which they were FDA approved. But that doesn't necessarily mean that, scientifically, that's the best way to use these drugs. So, Stephanie, as you mentioned, there's combination therapy to think about. There's sequencing to think about. So in addition to this map of FDA approved agents, I think there's more to come in terms of how we might think about using these drugs. Next slide. So what are the therapeutic classes of agents that we use in urothelial cancer? So the main class that we all kind of know about and have thought about is chemotherapy. So the gemdosi, which is short for gemcitabine and docetaxel, that intravesical therapy that Dr. McConkey was talking about and Stephanie was talking about, that's a chemotherapy drug. The other common chemotherapies that we give in urothelial cancer are the perioperative cisplatin and gemcitabine, or carboplatin and gemcitabine. And then there's another regimen called accelerated MVAC, that's methotrexate, vinblastine, azuromycin, and cisplatin. So those are the common standard chemotherapies that we give. There's an older drug called docetaxel, which we used to give in the advanced setting, but other drugs have kind of taken over in its place. There's immunotherapy. So BCG was the original ever immunotherapy drug that was developed, and of course now there's much more modern immunotherapy. So if BCG is a payphone, then pembrolizumab and nivolumab are an iPhone. There's targeted small molecule therapy that we use. That's oral therapy. That's for a minority of patients. And then we have two approved, FDA-approved antibody drug conjugates. Again, a very advanced kind of agent. So this is a class of agents that's used both in urothelial cancer as well as other diseases, and essentially kind of like a smart bomb of chemotherapy. So very rationally designed modern chemotherapy class of drugs. So those are the classes that we think about. So in terms of chemotherapy, just going to move my slides a bit here. The mechanisms of action of chemotherapy, this is a pretty busy slide. But essentially what chemotherapy does and why it makes people sick is because it inhibits DNA replication and transcription and causes cancer cell death. And it does this rather indiscriminately. So chemotherapy, I call it an old stupid drug. It does not know the difference between a cancer cell and your own, hair cells or gastrointestinal system. It indiscriminately will interfere with DNA replication. It's why people lose their hair. And it's just kind of given and expected that it's going to go through the system. So when our pharmacy staff, our really talented pharmacy staff that works, with all of our teams at every cancer center, when they carefully, mix those drugs, they do so based on an individual patient's height and weight. And then when, again, our talented nursing staff, gives those drugs as ordered by the medical oncology team, these are essentially powdered drugs or a liquid formulation that's, mixed up in saline and then hung and gives the patient. And those drugs are just circulating through the system and they interfere with what they interfere with. And that's how they cause cancer cell death. More rapidly dividing cells kind of take up the chemotherapy faster than non-rapidly dividing cells, which is in part the mechanism. But again, the technology for this is quite old. So the idea of some of the newer drugs we have use the same kind of chemotherapy idea with a different delivery system. So as you can see, I'm sorry, go ahead, Stephanie.
I'm going to interrupt you. As odious as chemotherapy is, however, it does work. I mean,
right. You're absolutely right. Yeah. So we use chemotherapy, we use BCG, not because we don't have other options, but because, there are randomized prospective phase 3 trials. And the reason I say that is because those are the gold standard of how the FDA makes their decisions about treatment choices and order in which they give them. So if something is prospectively, meaning in the future, evaluated in 2 groups of patients and treatment A improves overall survival versus treatment B or versus observation, that's the gold standard where the FDA makes their recommendations. And you're absolutely right. Chemotherapy gets a bad rap, but we give it because it improves overall survival for bladder cancer. But it is a hurdle to overcome in terms of having discussions with patients about giving these drugs. We haven't improved upon cisplatin since the 70s, but what we have improved upon is the supportive care that we give with it. So we know that we, give patients plenty of fluid, we carefully select the patients, we have really powerful supportive care medications, both for nausea and for neutropenia and potential infectious, side effects from therapy. So drugs, at least in that setting with chemotherapy, aren't better, but the way that we give them, I think, is better and safer. And the way that we choose patients is probably better than it was before. So you're absolutely right about that.
Thank you for all of those listening who have endured it or are going through it. There is a reason why it's used, and it is a helpful therapy, and it has been
right. It's stuck around for so long, not because there's no other option, but just because it's actually still quite good. And even though we have other tools in the toolbox, chemotherapy remains the standard of care for good reason.
Great.
So next I'm going to move on to immunotherapy. And I think we throw the term around a lot. And Stephanie, to your point, like, what does this mean? I know sometimes patients will ask for certain drugs or certain classes of drugs. And I think these are things that we've heard about or things that people have potentially Googled with the hope of, trying to educate ahead of going to a doctor's visit. Amazing, right? But like, what does all this mean? And so it's confusing. And I think, immunotherapy is kind of like thinking about, what's a soda? Like there's all different kinds of sodas. Soda is a big kind of umbrella category, but under that category, there's Coke, there's Pepsi, there's orange soda, there's grape soda, there's, there's sparkling water. All these things are the same thing, but some of these things can be very, very different. And that's kind of the same idea, I think, as immunotherapy. So immune checkpoint inhibitors, those are the drugs that particularly going to see on television. And the reason for that is they've completely changed the landscape of cancer care, not just for bladder cancer and upper tract urothelial cancer, but for 20, 30 different kinds of cancer. It's pretty amazing. It is the science and the technology that's led to a Nobel Prize being awarded, and has really kind of changed the way that we think about this. So those are the drugs, the pembrolizumab, atezolizumab, nivolumab, durvalumab, and avelumab. Those are those drugs. There's this kind of hot new topic about T cell transfer therapy. So kind of like taking.
Jeannie, I'm gonna stop you there. Sorry, I'm gonna
Sure.
stop you. So can we look at immune checkpoint inhibitors so people can understand that they actually turn something on or off?
Yeah, and we're going to talk about that in a later slide. I can move forward, or we can.
But that's kind of, they're doing something that's an
Right.
on or off switch. That's a
Yeah.
help to look at it.
Exactly. So when I think about this, and I use a lot of analogies, it's just the way that I think, and so I use these a lot in clinic as well. So some of the folks on the call have probably heard this more than once. If you've been with me in clinic at all as a patient or as as a practitioner in clinic, but your immune system was born the same day that you were. And just like your heart and your lungs and your bloodstream, it has a function, and that function is to recognize your own tissues, your own skin, your own lungs, your own pancreas, as yours, to protect that, and then at the same time become educated about different kinds of vaccines, different viruses, different bacterial infections, as well as cancers that are forming in our body all the time. So, cells are supposed to replicate, meaning they kind of split themselves in two and divide over and over again. And you can imagine that there's some errors that happen along the way, and people that have inherited syndromes that can cause errors to happen more often, they're more likely to get cancers. But the immune system is supposed to recognize that those cells don't look quite right, and is supposed to kill them. This mechanism of how does the immune system kind of recognize your own system, your own tissues, and at the same time notice that invaders are foreign, is through a system called the PD-1, PD-L1 system. It's almost like a blind system. I think of it like satellites and a space station linking up in space. So, if two different objects that are circling around each other have the same equipment, they can link up, and you're at a friendly space station. But if they don't have the same equipment, they can't link up, and therefore will know that they're probably not supposed to get along. And then just like maybe hopefully a space station wouldn't do this, or a satellite, but the immune system will recognize there's something not quite right about trying to get into that pocket, and then cause an immune response. And so some cancers kind of utilize, we think, that system of having the immune system almost like recognize that the cancer is more normal than not, but then there's something kind of not quite right. And the idea behind these checkpoint inhibitors is that they break that tolerance that the immune system has, almost making it a little bit easier for them to recognize something foreign, so that the immune system that's poised to recognize that there's something not quite right about a cell can actually go in and attack. That's a good thing when it comes to treating cancers. It can be a bad thing because that inhibition of that check can also lead the immune system to start kind of recognizing other parts of the body and cause, skin rash or diabetes or pneumonitis, which is inflammation of the lungs. So the mechanism by which it works is also the mechanism of how the drugs can sometimes cause some toxicity. Can you just go back a slide? So just in terms of going over the types of immunotherapy, the ones that we really use are these immune checkpoint inhibitors. T cell transfer therapy gets a lot of press because for some hematologic malignancies, liquid tumors, this has been somewhat revolutionary. As far as I understand, in solid tumors, solid tumors like lung cancer, colon cancer, breast cancer, bladder cancer. The work is not as far along, and the outcomes have not been as good. I'll just kind of leave it at that. There are monoclonal antibodies that also can interfere with the way that the immune system components interact. There's vaccines that kind of specifically can be made, as well as immune system modulators. So other kinds of drugs that can interface with these other checkpoints in the immune system that can turn on or off an immune response. So those are the main types of immunotherapy. Oh, and you can move on to the next slide. By the way, I do have information at the bottom of each slide of where this information has come from. So the NCI, the National Cancer Institute, has this beautiful website where you can go and kind of look through all these different things. So it's a great site, and I just lifted most of this information from there because it's really good information, and where there's information coming from other areas, I've pointed that out as well, but you can go back to that source. So what is this monoclonal antibody? So these antibodies are in our body. These are circulating in every single one of us right now. And antibodies are made by the immune system. They're specifically made by circulating B cells. The immune system is made up of a bunch of cells, but you probably hear about T cells and B cells. B cells are the ones that make antibodies. And when somebody has an infection or somebody has some kind of an issue, these B cells will start pumping out clones of an antibody that the goal would be that they can fight off a foreign protein, and those proteins, when they are attracted or make an immune response, are called an antigen. So that's just the word that we use. But it's really something that is not quite right that the immune system recognizes as foreign. So that's what an antigen is. So when monoclonal antibodies are developed in a lab, it's really just recapitulating what is happening in our own bodies, but doing so in a way that when we as scientists and researchers recognize that there's certain antigen that's of interest that the immune system could be more active against, that those antibodies are produced in a laboratory setting as opposed to produced in somebody's body. And there's various different ways that can get done. I think Dr. McConkey could probably do an entire lecture on how people make monoclonal antibodies, but this is a huge, I would say business, but these are made for a variety of different reasons, for all different kinds of therapies, not just cancer therapy.
I hate to interrupt you, but we heard a lot about them too with the COVID vaccine. Is that correct?
Exactly right. Exactly right. So a lot of those vaccines are, made with some of this technology. And when technology advances in one arena, Stephanie, I mean, it advances in others. So, we've definitely heard about, trials and ideas that really build upon this wave of research and development that has been going on, in different arenas. And we're also used to saying and hearing about, a drug that works in one setting for one disease, may have interest in another. So that's something that we're used to. And so the idea that research in the COVID setting may translate into research and development in cancer is no surprise to us.
Great.
So these monoclonal antibodies, this is a cartoon of kind of that antibody that you just saw at the molecular level of what it might be doing when it circulates and then meets cancer cells. So the ends of those antibodies are like heat-seeking missiles. And so they are circulating in the system and almost like a magnet. They're just looking around for something that they're going to be attached to and then grab onto. And those are those antigens, or those kind of funny proteins on the outside of the cells. So here you have a monoclonal antibody, and then this antigen protein that the cell produces that can then cause the immune system to respond. And then the antibody locks onto that antigen, and then it can work in different ways. So if that antibody is attached to another drug, like an antibody drug conjugate, that'll get taken up and kill the cell. If that antibody's job is to attract other immune system cells, then the own body's immune system will come in and attach that antibody. So depending on what the other working end of that antibody can do, different things can happen because of the use of that monoclonal antibody drug. So this is a cartoon about that immune checkpoint inhibitor mechanism that I spoke about earlier, that idea of kind of the blind satellite linking up in space with a space station. So on the left-hand side, you'll see this cartoon that says PD-L1. binds to PD-1 and inhibits T cell killing of a tumor cell. So you see here on the left-hand panel, there's a tumor cell. That tumor cell has this PD-L1 protein on the outside. And then the T cell, which is the immune system cell, has PD-1 on the outside, as well as this receptor. So those two things will interact. And if you have an anti-PD-L1 inhibitor drug here on that right-hand side, where the red triangle is, you can see that that interferes with an interaction, so that the immune cell is recognizing that there's something not quite right about that tumor cell, and then induce that tumor cell death.
Got it. Got it. Jeannie, for the sake of time, let's be more specific to bladder cancer, and also
Sure.
maybe just because I think there's a lot more to cover. I hate to do that too, but we also have
That's
some
okay.
too. So,
Yeah,
monoclonal
absolutely.
antibodies are used in bladder cancer. You're going to tell us the name of the drugs in a minute, and then checkpoint inhibitors are the name of the game in terms of these new cocktails and the new
Right.
drugs that we hear about. Fantastic. Okay.
Exactly. And then that segues right into this slide, which is a nice summary of all the different immunotherapy or checkpoint inhibitor drugs that that we have that are FDA approved, and then the setting in which we use them. So even though we have 5 of the drugs approved, we don't use them all in every single setting. So this is just kind of a high level summary of that. And I'll leave it at that. But this is I think a good reference to look back on, in addition to kind of where those studies were published for people who are interested in that.
So Jeannie, I'm going to interrupt you. These drugs, are they given intravenously? Is that mostly how they're given, and how often? And
Yeah, Stephanie, so it depends on the drug. So yeah, the first question is yes, all of them are given intravenously. I think that pharmaceutical companies recognize, because these agents are kind of so pervasive in the oncology space, that having a more convenient dosing paradigm is a really important future plan. So I know that some companies are working on different formulations, like subcutaneous formulations that patients might be able to give at home. There are some oral immunotherapy kind of platforms, but for the most part, as far as I know, the plan would be that the drugs are intravenous for the current time being. And I know of nothing in the next year to 2 that may change that. David may know a little bit more. In terms of the timing that we give the drugs, it's variable depending on the drug. The platform is either every 2 weeks, every 3 weeks, every 4 weeks, or every 6 weeks. And it just depends on the drug and the setting in which you're giving it.
is it a less sort of odious experience, would you say, than chemotherapy in your experience? And is it well tolerated?
Yeah, so I think that it's a different experience than chemotherapy. And so when I explain this to patients, and because when they ask, is this stronger, is this less, is this lighter treatment? It's the difference between a hammer and a computer virus. Both things will interfere with your ability to use your laptop, but they do it in very different ways, right? So you might not even notice that a computer virus has gone in, but that will destroy your ability to run a program like this, as will taking a hammer to your computer, right? So these outcomes and the side effect profile can be very different for different patients. Some people have no toxicity, no side effects whatsoever from immunotherapy, and they have a great response, and that's wonderful. We like seeing that. Others have a lot of side effects and no clear response. But getting immunotherapy, it's a switch. It's a way. It changes the character of the immune system and how the immune system interacts with your own body. And getting one dose can have long-lasting effects. Some people on the call may have already experienced that, so it's something that we have to keep in mind. If the immune system starts to really ramp up and attack the person rather than the cancer, or in addition to the cancer, then we have to try and turn off that response. And the way in which we do that is with immune suppression drugs. We start with steroids at high doses, and if need be, we use drugs that we use in the transplant setting to try and calm down the immune system.
Jeannie, I have 2 questions. As someone who's hair obsessed with immunotherapy, we get this question a lot. Do you tend to lose your hair that's important to patients, or is that?
You don't tend to lose your hair, but at the same time, immunotherapy can affect any organ and any organ system at any time. So I have, had an unhappy surprise. I say in our business, we have good surprises and bad surprises all the time. So I've had an unhappy surprise of having a patient have an immune related event where they lost their hair. So it's pretty uncommon, but it's not a never, just like I think anything in medicine. And so having a discussion about what the anticipated risks are in the setting of the hopeful benefits, I think is important for no matter what we do.
I have a question in the chat. Thank you, Vicky, about screening. So is it a given that a PD-1 or PD-L1 is for everybody, or do you have to pre-screen patients to know if a checkpoint inhibitor will work for them or a monoclonal antibody works for them? Do you assume they have that's in their genetic makeup, or do you have to screen for that? And if you do, how do you do that?
This is a really good and really complicated question, and could be the kind of fodder for a complete another talk for an hour. So I think that a lot of emphasis was put on PD-L1 testing on a tumor. It's called a biomarker. And I think early on, a lot of emphasis was put on that because understandably, you want to try and understand who's the right person at the right time for the right medication, right? So what characteristics does the tumor have? And so because it can be measured, it was measured. But at the end of the day, for patients with advanced bladder cancer, we don't make it, we don't predicate treatment on that biomarker. So we wouldn't withhold a treatment for someone whose tumor didn't have a PD-L1 biomarker. And the reason that we don't do that is because even though the response may statistically be lower than someone whose tumor has a very high biomarker, that doesn't mean it potentially wouldn't work and wouldn't work like gangbusters. So, in the clinical space, we've seen high biomarker tumors not respond, low biomarker tumors respond, and everything in between. So for better or for worse, and I think this is for better, we do not use that PD-L1 biomarker to make clinical decisions in bladder cancer. The same is not true in all cancers. And so some cancers rely much more on this. I think some doctors have different ways of thinking about this, but in my practice, I really do not use it on a routine basis. We get the biomarker, we think about it, we talk about it, and in part, it may be because we have a variety of different options to think about. But at the current time, we do not use it to make decisions.
Wow, that's so helpful. Thank you. That's
Sure.
great.
So what the next class of agents is targeted therapy. And this kind of is what it sounds like, right? And when we talk about research, what does that mean? It seems like it's such a basket term for kind of everything. It is from understanding what are the targets, meaning like what are those different antigens? What are those different pathways? What is different about a cancer cell, a cell that figures out how to turn into a urothelial cancer versus the normal urothelial cell that's sitting right next to it, right? So if we can capitalize on what those differences are, then we can target therapy to the cell that has something wrong with it, and then hopefully spare the normal cell. So that's the whole idea behind like what targeted therapy is. And so there's different kinds of targeted therapy, checkpoint inhibitors. There's immunotherapy drugs, the pembrolizumab, those drugs are targeted therapy because they're antibodies that are working on that PD-1 system. There's targets that can stop cells from growing, like erdafitinib that we talked about. There's a whole class of medications that can interfere with blood vessel growth. I mean, cancer cells, they need fuel, and that fuel comes in the setting of blood vessel distribution. So there's a drug called bevacizumab or Avastin, and other drugs in that setting that interfere. There's drugs that can deliver substances to cancer cells and do that in a targeted way. There's hormones, right, that starve prostate cancer. So there's all different kinds of kind of cool ways that once you understand more from all the research that's done, on what makes a cancer cell grow that you can target to turn that fuel source off.
Got it.
Next slide. So this is an example of a targeted drug. So this is an antibody drug conjugate called trastuzumab deruxtecan, which is being used in breast cancer as well as other cancers that have this target called HER2, which is an abnormal protein on the surface of cancer cells. So this is an antibody with drugs connected to it that delivers chemotherapy instead of just circulating through the body, kind of directly into the cancer cell, which is pretty cool.
Jeannie, I'm going to ask you a question a little bit off script here, but these drugs which have been developed are also being deployed in many other cancers, melanoma, breast, lung. Is that true? Like these class of drugs are sort of carpet bombing other cancers as well, not just bladder. Is that correct?
No, absolutely. Yes, they are, which is great because it means, with a rising tide raises all boats. So the research that's going on in one arena, is translated into others. The immunotherapy drugs were initially developed in melanoma in part because no chemotherapy drug ever worked for them. So when you took a group of patients where there really was no good, clear standard of care other than early immunotherapy, which is called IL-2, which is very kind of potent and toxic. That was the first group of patients where immunotherapy was tested, and then kind of understanding that bladder cancer is a very immune responsive disease. That work got translated, into our practice, and so yes, absolutely. The drug that we're going to talk about called sacituzumab govitecan, all the way at the bottom of the list here, that's a breast cancer drug that has now extended FDA approval into bladder cancer. So the development in other areas can help patients with bladder cancer as well.
Jeannie, for the sake of time, I have not so much a closing question, but say you're being treated for non-muscle invasive disease, you're not at Hopkins, you're in a community setting, which is great, and hopefully you're getting fantastic care. Should patients be asking for these drugs if they're not offered, or under what kind of scenario? We're trying to educate our patients about, the availability and this robustness in drugs that's come along. What would you advise patients to do in terms of if like in their, not to say that they wouldn't be offered them, but if they're not offered them, to sort of ask for them? Is that appropriate? Or I know everyone's case is different, but this is a whole new frontier now, and is this something that patients should be asking for?
Yeah, I mean, I think that it's challenging when a patient comes in and like with an article or with a drug, it says like, can I have this? And we may or may not have the time to discuss like all the reasons why that would be a yes or a no. But one way to phrase the question is to say, I'm getting this. If this doesn't work, like what other classes of drugs might be next that we can think about? I want to try and understand this. Where can I go to look to better understand like what might be next for me? And I think that that's a good strategy to think about that. The internet is a dark and scary place, Stephanie. And I think that it just gets bigger every single day and more confusing. And especially in our space, like to think about bladder cancer and like what's out there. If you just Google bladder cancer agents, that doesn't mean that webpage is appropriate, like for the person who's asking the question based on how many treatments they've had before, and whether or not they have a localized disease or advanced disease, and then not to mention all clinical trials. So it's a tough and confusing question, but that's why we love having these talks, and the repertoire that you guys are putting together. I think our partners at BCAN, cancer.net, National Cancer Institute, like these very renowned, I think safe sites for patients to go on the internet that I think do kind of break it down a little bit more digestible snippets about the medicines.
Well, the takeaway is these are FDA approved, so there's been a lot of science behind them, and it's not like snake oil, but it's how to put it all together and have the best options for the best care is kind of where we're aiming. So it is 4:59. Thank you, David, for answering. I hope all the questions in the chat. If we didn't answer your question, please send us an email to bladdercancer@jhmi.edu and we will answer it. And David, please pipe in and share any sort of thoughts you have on, David's in the laboratory and also running a Bladder Cancer Institute. So he knows the science behind this, and the science is fast moving. So any parting thoughts, David? And Jeannie, thank you for an incredible presentation.
It's a very exciting time for us and for our patients. There's a lot going on. And as Jeannie pointed out, it's really important to go to the right sources to get information about what's going on. I'd just like to underscore that.
Absolutely. Beacon, our talks, other academic medical centers have many talks, but yeah, I mean, get the best knowledge for
Absolutely.
you.
And get navigated by the right people, because with so many choices out there, it makes more difference than ever to make good decisions.
By the way, it sounds like a shameless plug, but for pathology, Hopkins does have a second opinion service, and Dr. Matoso gave a talk. It's on our website a few years ago, and in terms of just pathology reports can sometimes be erroneous and maybe benefit from a second opinion. If you ever want a second opinion or feel that you're just not sure or clear about your care wherever you are, always seek a second opinion. And also, we just had a talk not too long ago about it's okay to get a second opinion, and all our beloved physicians really endorse that. So get the best care you have, get the best information. If you have any questions, please reach out to us. And thank you for a wonderful session. We will share your slides, Jeannie, if you don't mind, on our webpage when we upload this talk, which is recorded. I hope everyone, we answered your questions. Our next session, which is really cool, because we try and probe for things that people want to know about that's maybe never talked about. So as David mentioned, our next session is on March 28th. Chemo brain is real. It's a scientific real thing. It's not your imagination. You're not crazy. If you're going through it, we have Dr. Vanderstal is a neuropsychologist who will sort of walk us through that. It's a real science to it. No, it's not your imagination. And in our women's program, which is anyone, a caregiver, we have a women-only program for a reason, just because it's a little bit in a more intimate setting. We have Dr. Karen Schwartz, who's a Johns Hopkins psychiatrist. She's amazing. And her field, which is a field that all of us can relate to, and all of you on the call can, is to talk about stress, depression, and cancer, and how they're all related. A really serious topic, and we want to, share Dr. Schwartz with you. So thank you all for a wonderful session, and please reach out to us if you need us in any way. We're here for you. Thank you, Jeannie, so much. Thank you, David.
Thanks, everyone. Have a good
you.
evening.